Well, thanks for joining us. So, as Andrea said, Dr. Fasano did an excellent job of reviewing DBS a couple of weeks ago in the holistic program. I encourage you guys to look at those programs because they're all very, very good. So I'll just give a little bit blurb about what is DBS, but really this is, for you to have a chance to talk to another patient who's had DBS. So I always encourage patients before they have DBS or DUOPA to talk to a real life patient who's on therapy so that they can tell you the good, the bad, and the ugly. What fears did they have before they had the procedure? What were their questions? Who they talked to about the procedure? And so I think it's important always to get it from a patient's point of view. So basically what DBS is, or deep brain stimulation, is, we put 2 leads in the brain and that helps us control some of the motor symptoms of Parkinson's disease. So things like tremor. So if you have a tremor that we can't control with medications, or we have to use such a high dose of medicines that you develop dyskinesia or hallucinations, DBS is a very good way of controlling the tremor in Parkinson's disease without having to use a lot of medicine. The same thing also if you're on levodopa, if you're on medicine and every time you take a dose of Sinemet or levodopa, you have on time, but it's with dyskinesia, the extra wiggly movements. DBS is very good at giving you on time without dyskinesia. So getting rid of those involuntary movements that you have with the medication. And then it sort of helps stretch out your medicine, makes it last longer. Again, like the medicines for Parkinson's disease, they make the motor symptoms of PD better. They don't necessarily help the non-motor symptoms. So many patients feel like, well, if I do DBS, is my swallowing or my speech or my freezing of gait going to get better? It's not. It's only the motor symptoms and mostly tremor and dyskinesia that you get with the medicine. So it's very important before you proceed with the procedure is to have a good idea of like what your expectations are. What are the symptoms that are going to get better with your DBS? Because many patients feel like, well, my problem is mostly balance, freezing of gait. I'm going to go do DBS. DBS is not going to help that. And so today we do DBS earlier rather than later. So the more cells there are there to stimulate, the better the patients do. So usually around 5-6 years into your disease, then we would consider DBS if you've developed on time with dyskinesia or you have a tremor we can't control. So any quick questions about what is DBS? So today we're really lucky. Today we have 3 different companies that make the DBS hardware. So we have lots of choices. We've got rechargeable units so that you have a battery that you can charge up and it's last up to 15 years. And then today you can program your unit. You have control over your unit if that's what you want to do. So you can go up or down on your stimulation and it gives you more control than what we had 10, 15 years ago. So the hardware has been upgrading very quickly. And now that there's competition and there's 3 different companies, we're going to see that hardware evolve a lot faster and get much more patient friendly. So now most of the companies have, it looks like a little Samsung phone or an iPhone. So it's much easier for the patient to use the patient programmer than what it was before. And also much easier to charge the unit. So any quick questions before we bring on Clint?
Okay, and before you join Dr. Ospina, I was encouraging people to unmute themselves because we want to interact wherever you are in your living room across the country. I do have, while people are getting those queued up, I do have one from, let's see, from Victoria. She said, if your tremor doesn't respond to carbidopa, levodopa at any stage, will you respond to the DBS?
Yeah, so DBS works well for some patients. Their tremor doesn't respond to levodopa, or we have to use such high doses of levodopa that you're hallucinating on 3,000 milligrams of levodopa. So DBS is a very good option in those patients. Also, some patients we have to use anticholinergics like Artane to control the tremor. Because anticholinergics have long-term cognitive side effects, we don't like to use them in Parkinson's patients. So in those patients, we can use DBS or deep brain stimulation in those patients. And then I saw a question sort of flash by. Somebody said that if you have not taken any medicines, can you still be considered for DBS? So usually we would do the oral medicines first, and then we would consider DBS after. We wouldn't go right into DBS unless it was a tremor patient that we couldn't control with Sinemet. But usually, remember, always we want to be in the least invasive therapy before we go drill 2 holes in your head and put some hardware in there. So usually the patient would be on some sort of oral therapies about 5 or 6 years before we would need to use DBS or deep brain stimulation. The same thing with Duopa. You know, although it's continuous and it works really well, we're going to use Sinemet and then Rytari and then consider Duopa. We're not going to go straight to Duopa because it requires a PEG tube. So that we would always be using the least invasive therapy first. Because always we want to make sure that the benefits of the medicine outweigh the side effects of the medicine. And DBS requires surgery. And so we want to avoid any morbidity or trouble with the surgery if you can just control your tremor with, you know, 1 or 3 tablets of Sinemet a day.
Okay, very good. So if everyone's being shy and I don't see anyone chiming in, I see some more questions that I'm going to bring in Clint at this point. So Clint, did Dr. Ospina's description, you know, match you and what you were experiencing when you decided to, first of all, even consider, you know, neurosurgery?
Well, when I came to Dr. Ospina after I'd been 2.5 or 3 years of trying not to take any medicine. I tried every holistic thing they had with no relief. Maybe a little bit of comfort once in a while, but nothing that lasted, and certainly nothing that could help with the tremors. And so by the time I got to her, I was pretty much tremor, walking tremor, or a shuffling tremor. Let me change that. And then she explained the whole thing. The reason I didn't want to do the medicine was I'd been on the internet, which is, you know, a black hole of information, and you go down the one, you just get way down it, and you can't tell if somebody's posting something that's factual or what the deal is. So the reason I didn't want to do it was everything I read on the internet just said the medicine works a little bit, and then after a while it doesn't work, and they have to keep taking more and more and more. But Dr. Ospina explained to me that as your cells are dying is when the symptoms start coming on, and so you start taking medicine. And just because you're taking the medicine doesn't mean the cells stop dying, more die. That's the only reason you have to take more medicine. But by the time, she said, you're going to have to take it eventually. You just have to decide when that is. Well, I had used up every avenue that I had or that I knew of, and I said, you know, I'm ready, but I want to talk to my wife first. I talked to her and instantly started taking, I call it dopamine. What was I taking? Sinemet. I take Sinemet. And it probably only took 2 or 3 days when I had instant effects of the tremors stopped, or at least slowed way down. One little thing, this was something I was driving, and I was going up the on-ramp, and the sun was in my eyes. I reached up and pulled the visor down. It scared me so bad I almost went off the road because I hadn't used my right arm in a couple years naturally. I could make it do anything. I could say, pick up the pencil, and I could think about going and picking up the pencil and think about writing with it, but I couldn't naturally just pick it up and write with it, or I couldn't put the visor down without saying, okay, I need to get the visor, get a grip on it, and slowly push it down. The sun was in my eyes, I put the visor down, and holy smokes, I did that without even thinking. It just, the naturally of it came to me. A couple of days later, I was backing out my driveway. I got the same feeling like, ooh, so I stopped real quick to see. I didn't know something was different. And then I realized I was looking out the back window. I hadn't been able to turn my head and neck been loose in a few years to where I could turn my head and I look out the back window. So I thought I had the cure the cure for it when I got the Cinemat. But eventually, because I was pretty far along, I had to keep upping it and keep upping it. And I kept working out and things, but I just got to where I had to take so much that I started getting dyskinesia. Well, then the dyskinesia got worse and worse and worse and worse. And I couldn't take less because then I couldn't move. I needed to take more so I could move. And I took Rytari so I didn't have to take it so often. But the bottom line was now I got jumping bean syndrome because I had so much dyskinesia I can hardly sit still. It was easier because I won't get into that. Remember, I always say that tremors use your mind because it tires you out because your brain makes you shake, but the dyskinesia doesn't use your brain, so you shake a lot and move, but it doesn't tire your brain out because it's involuntary. So that wasn't as bad. The dyskinesia was better than the tremor, but I took a lot. I took a dose every hour and a pretty good dose. And finally, I just got to the point where I had to do something. And so that's when the DBS came up. And what I did to find out about it was I got a list of people from the doctor that said, these people have DBS. You can call any of them and talk to them that you want to. And I called everybody on the list. Some people were Parkinson's, some were essential tremors, but I had a hard time finding somebody that was as advanced as my symptoms were. But I finally got a hold of one guy, and what he said was, I drive with confidence now. And I knew what he meant. I knew exactly what he meant because I drove and I felt okay, but it took all my concentration to drive. And I wanted to drive just naturally, you know. So that was the kind of the extent of my research, was talking to people that had it. But everybody, no matter whether they said they were perfect with it or how they were, everybody said they were better than they had been before. And the big thing was everybody said they do it again no matter what. So I felt like, you know, that was enough for me because I was pretty, yeah. Right now I have to tell people I have Parkinson's. And I told Dr. Ospina I'm cured, but she says no. But nevertheless, I have to tell people that I have Parkinson's because I don't have any tremors. I don't have any dyskinesia. Right now I take it's been almost 2 years since I've had it. I take, I don't know how to do percentages or milligrams or whatever, but I take 1 tablet and a half tablet. I'm down to 3 times a day, where I was taking way more than that every hour before. And I just take it to keep me loosened up a little bit, but that's all.
So your DBS, did it reduce the amount of time that you take?
I'm going to have to.
So
I think the question was, did it reduce the amount of medicine that he?
Oh yeah. I take 1/10 of what the medicine I took before. 1/10. Yeah.
I take more. I have a DBS and I take more. I take about 20 pills a day. Same as your day.
No, for me, it worked out that I take a lot less. And I didn't take more than I needed before because, like, to get tested, I had to do, for my insurance, I had to do off testing where you go and with no medicine for 12 or 24 hours or something like that. So I went without before, and then I was like a statue. They had to hand truck me into the doctor's office to get the off testing. But
yeah. I don't know what I'd do if I turned my DBS out and stopped taking my pills. I'd probably die.
I take 1/3 the meds I took before.
Yeah.
So let's talk a little bit about the medicine. So Clint brought something up that happens a lot, especially on patients who read a lot of stuff with Dr. Google. They come into the office and they have this levodopa-phobia because they read on the internet that after a couple of years, the medicine doesn't work, or that you get dyskinesia. So it's actually the course of the disease. So remember that in Parkinson's, you've got these cells deep in the brain that produce dopamine, and for whatever reason, they're dying off. So when you first see the doctor, your motor symptoms, those are things like tremor, rigidity, bradykinesia or slowness of movement, and trouble with gait and balance. 60 to 70% of those cells that produce dopamine have already died off. So we've already got this huge deficit. But as the disease progresses and time goes on, you continue to lose those dopamine producing cells. So no matter what, whether you start levodopa or not, that cell loss is going to continue. So the reason that you start medicine 1 tablet 3 times a day if you're on Sinemet, the carbidopa levodopa, and then 6 years later you might be on 2 tablets 5 times a day or more, is not because the medicine, you were habituated to the medicine or you've become tolerant to the medicine, is that you've continued to lose dopamine producing cells, and we need to replace more of that dopamine with the medication. So it's just like a diabetic who has to take insulin because their pancreas can't make insulin anymore. So as time goes on, we have to increase your dose of medicine to replace the dopamine that you're no longer able to make. And that happens whether or not you have DBS or not. So DBS doesn't stop or reverse the decline in Parkinson's disease or cure Parkinson's disease. It continues to go. It allows you to take the medicine without the dyskinesia. So many patients, especially young patients that are done early, many of them, when we do DBS, we can reduce their medicine burden so that we can make that medicine last longer. And then as the disease progresses, we slowly have to go up on the medicine because we're replacing that dopamine loss that's happening from the cell loss. In patients who are done later in their disease progression, so they're done like year 10 or 15, many times we can't reduce the medicines at that time. They stay on the same medicines, but they can take the medicine without dyskinesia or the involuntary movements. But as the disease marches on, we have to replace more and more of that dopamine with oral medications, or in some patients, with Duopa. And so Duopa and DBS patients do really, really well because they're on continuous therapy 24 hours a day. So they're not having these peaks and troughs that you get throughout the day in patients with Parkinson's who are taking medicine every 3 or 4 hours. So everybody is different. Some people, we reduce the medicines by half. Some people stay on the same medicine. And as the disease progresses, you continue to take more medicine. But that's an important thing, is that levodopa phobia that people get from reading their Dr. Google information on the internet. There should be no reason to be afraid of medicines, or especially Sinemet, levodopa today, because it's not starting it early that gives you dyskinesia. It's the progression of the disease that leads to dyskinesia. So our goal is to make you as comfortable and as whole as we can with the medication. And it's super important to be well medicated, because the better medicated you are, the more on time you have. The more on time you have, the more exercise you can do. And that's the only thing that makes those cells live longer. So the more you exercise, especially aerobic exercise, the one that gets the heart rate up, that makes those cells make new connections. The more connected they are, the more robust and healthy they are, the slower they die off, the slower the progression of your disease. And Clint is a big exercise proponent. Maybe you can tell the people.
I don't exercise. Go ahead, sorry.
So I have a couple of questions. I've heard that it helps tremor on one side. Or is that the ultrasound?
So that's another good question. So there's something called focus ultrasound. So many patients, because now they've done all sorts of advertising for focus ultrasound as an alternative for DBS or deep brain stimulation. So DBS is still the gold standard for tremor control, both whether you have essential tremor or a Parkinson's tremor, because we can do bilateral, both sides, and we can program the stimulation. So we can go up or down, especially in Parkinson's, as the disease progresses, we can titrate up that stimulation to control your tremor. Focus ultrasound is an alternative for patients who are not surgical candidates. so you don't have a good heart, good lungs, you can't do general anesthesia, then we would consider focused ultrasound in those patients because we don't have to do surgery. We just sort of focus this ultrasound beam and zap, make a little lesion, but we can only do it on one side. So if you have tremor on both sides, we can only do one. And we can't program it. Whatever you get in the OR at that time, that's the tremor control you're going to get. We're never going to be able to change it from there. So it's something that we only do in patients who are not good surgical candidates and who maybe have essential tremor that's worse on their dominant hand, and we don't need to worry too much about their non-dominant hand.
So I have two other questions. Number one, does that limit you from doing anything? Number one. And does DBS by itself causes any kind of side effect besides, I know there's a risk of infection after any length of time?
Right, so because DBS is a surgery, anytime we're cutting through the skin, there's the risk of infection and there's the risk of bleeding. Because we're in the brain, if there's a bleed, then we call that a stroke. So it's very, very minimal, but it is a risk factor. So far we haven't had any, I mean, the risk for infection, bleed, stroke, or seizure is very low in DBS. It's not like, you know, having your, like your gallbladder taken out or a hip or a knee replacement. That recovery is much greater than it is for DBS. But for DBS, everything that you're doing the day before, you're doing the day after surgery. There's not 6 weeks of rehab or that sort of thing. But there is that minimal risk. And then side effect wise, so when we do bilateral DBS, then this is more for essential tremor patients who don't have voice or gait difficulty. So ET or essential tremor who just have a kinetic or a tremor, an action tremor where they're going to pick up a fork or a spoon or pick up a cup, they notice if we do bilateral both sides and we crank the DBS way up, they get dysarthria or this like hoarse voice, and also they have some balance difficulty. Parkinson's patients, because they are already hypophonic, they already have voice difficulty, they already have balance difficulty, they don't really notice those side effects because they had that before DBS. But for essential tremor, they do notice that, and there's many ways we can treat that. Remember how we said that now you can control the stimulation for your DBS? So in many patients, we can have them crank it up when they're using a screwdriver or cutting carrots, and then turn it down when they want to talk on the phone. Or we can turn one side way up, like your dominant side, and turn the other side down. So you can control your stimulation, and depending on what activity you need to do, whether it's to sing in the church choir or to cook dinner, you can control the stimulation and the side effects that way. But yes, there are side effects. I mean,
is there any limitation? Can I swim or water or anything like that?
Yeah, so there are, I mean, and Clint is super active, and he has snowmobiling and all that sort of stuff. I mean, why don't you tell us your history with DBS, the things you're still doing, if you have any.
6 days from the day I had my brain operated on, I went to the World Championships for snowmobile racing. So if you're going to do that, I might recommend you do a few more than 76 days, but it can be done because I did that. I set a goal because at the physical therapist that they gave me when I got the DBS told me I couldn't lift more than 10 pounds for 60 days or 90 days or something like that. And I pleaded with her to let me do more, but oh well, we got past it. But I set a goal that I would bench press 300 pounds by 1 year later. And about 6 weeks short of 1 year later, I bench pressed 300 pounds. So when my plug stayed in, so it didn't hurt anything.
How about swimming?
Yes, I swim now. I have, because of the Parkinson's, I tried to swim before, and I got a swim coach. I tried everything. I just couldn't make my legs and hands and arms all work together to swim. But now, one thing different is I use fins when I swim, but I swim about 3 days a week. I swim 200 meters. And every week I cut 1/2 inch off my fins. So someday I'm going to be able to swim with bare feet again. But right now I have fins. In my neighborhood is a trail called the Steps or the Stairs. It's 200 feet up, 320 steps. I try to do it every day, but I'll be honest, some days I'm not up for it, but I usually do it about 4 days a week. That's helped me with my regular walk quite a bit, because even though I don't have the shuffle, I hear myself around the house when I'm walking, the bottoms of my feet, just a little bit, but the steps make me pick my feet up to go up them. So every day it helps a little bit more. In fact, I used to wear flip-flops every day for 10 years, but then for 4 or 5 years, I couldn't wear them because I couldn't figure out how to squeeze my toes to make them stay on. But now I'm slowly getting back to where I probably wear them 3 or 4 days a week now, flip-flops, because I don't have to think about it. I haven't always, but through my Parkinson's years, I've always had to think about walking quite a bit, and I'm getting better and better and better and better to where I don't think about walking hardly at all.
And what about travel? Someone asked a question about in the airport. Do you still travel a lot, Clint? I don't imagine the snowmobile championships were in Arizona, so.
Yeah, I flew to Santa Barbara this weekend. When you have to stand in the thing like with your hands up, I flex as hard as I can so that my biceps show up on the screen, so they have to check and see if I've got something there. This week I've flown a bunch since I've got the DBS, and I was all proud. They gave you a little card to show that you've got it, but nobody's ever asked for it. And this weekend was the first time they just feel for it right there. I just pull my shirt down and show them the battery. I'm through. But I went to Cuba last year, no problem. I've scuba dived with my DBS. So that one I scuba dived before. I have to be honest, I was a little bit timid of whether I could go. I asked Dr. Ospina, she said, yeah, sure, no problem. So I went to the dive shop and I went in their pool in the shop. It's only like 14 feet deep, and I tested out, no problem. So then I've been scuba diving since. So it doesn't keep me from doing anything, and it has let me back into doing everything. Yeah, I just got to where I was so dyskinetic, or if I don't take the medicine to get dyskinesia, then my tremors so bad that I didn't drive my grandson drove me everywhere for, I don't know, 6 months, 7 months, something like that. Finally, I just said, I'm not that old. I gotta get myself back here. And
how long ago?
I had it put in 2 years ago.
And speaking of years and timing, there's been a couple questions, can you be too old for DBS? And then also someone asked, they're trying to play the timing game. Should I do it right away since I'm young and I'll recover? Should I wait since I'm kind of okay right now? What do you do you hear this a lot, Dr. Ospina, and what do you tell patients?
So, we do DBS when you need it. So if you don't need it, if you don't have a tremor, we can't control it. If you're not dyskinetic, we're not going to put hardware in your brain. But if you need it, then we'll do that. And then it's important what your functional age is, not your chronological age. So the oldest person to ever have DBS is a patient for essential tremor, a lady in Florida who was 104. And finally said, hey, you know what? I'm sick of having this tremor. And so it's really your functional age. How good are you as a surgical candidate? And then to answer the other question, nothing's hanging out like there is in Duopa. There's no peg tube. There's no wires hanging out. Everything's under the skin. So as Clint said, you can go scuba diving. You can do whatever you want. Nothing's hanging out. Everything's contained in, even if you're an RC, a rechargeable unit, it lies over the skin, and there's nothing that pokes out or anything like that. So it's your functional age. So we do plenty of DBS patients in their 80s without any difficulty, and we do it when it's necessary. So always we want to make sure, do the benefits of the therapy outweigh the side effects? If we can give you more on time with less dyskinesia by switching from Sinemet to Rytary, we're going to do that before we consider surgery. But if we're at Rytary 5 times a day or more, and you have a lot of on time with dyskinesia, then we would consider DBS or Duopa. Or if you're taking Sinemet every hour, every 2 hours, having on and offs all day long, then we would be considering DBS at that time. The same thing, so the flexion point for DBS and Duopa are about the same. Duopa is that gel, it's, you know, the peg tube that use the levodopa gel that goes straight into the tummy. And so most patients today, because they're more familiar with DBS, when we give them the option, they choose, like Clint, they choose DBS, the more invasive procedure, because they're more comfortable with it. They know people who've had DBS, although Duopa is a less invasive procedure and fully reversible than DBS. You know, if we don't like it, we can take the tube out and it goes, you know, the stoma closes and we're back to taking oral medicines. Whereas once you get the hardware in, we're not going to take that stuff out unless it gets infected, which is very rare. So once it's in there for life.
I wouldn't want it out either.
My experience with TSA and air travel, by the way, hi, Dr. Ospina.
Hello.
My experience with TSA is you mentioned DBS and they all know what to do.
What do they do? Because I never tell them, I just sneak through.
I tell them DBS and I get priority and I go through the machine with my hands in the air.
Yeah, I do go through the machine, but I've been through the other thing too, and it didn't turn it off, so I figured it must be okay.
The other thing I'd like to mention, exercise. I hiked the Grand Canyon 5 times after DBS. And I'm riding my bike 5 miles a night.
Right, exactly. More plugs for exercise. Remember, your medicines, DBS, Duopa, they don't stop or reverse the disease. They don't slow it down. The only thing that does that is exercise. Remember, the exercise is going to do more for you than any pill we can give you. And just like you want to have a well-balanced diet, you want to have a well-balanced exercise program where you have the aerobic exercise, the one that gets the heart rate up to keep the brain young and healthy, and then resistance training to keep your muscles and your bones strong and healthy. So hey, Clint, you can maybe tell them what your exercise program is throughout the week.
My exercise, I work out, I don't exercise. I try to lift weights 3 days a week. I don't always. I have to be honest. A lot of times it's 2 days a week. But I'm on the go a fair amount too. So that kind of limits, especially with the COVID. If I go somewhere and stay at a hotel, the gym is closed now. So that kind of limits that. I do the steps, like I said. I try to do those every day. I've been pretty good lately doing every day. I swim. Any day I can't do the steps, I swim. So I used to do an elliptical. I didn't do the treadmill all the years because I couldn't figure out walking good enough to stay right side up doing a treadmill. But an elliptical moves your arms and your legs and it guides them both. So that was really good for me as far as it helped my walking and it kept me cardiovascular good too. So I get cardiovascular in, something in every day, whether it's the steps or the swimming, and I try to lift weights or do some type of workout 3 days a week. And it's not always easy. I mean, but can I say my line? It's a lot of work trying to be normal. But it's better. It's better than the alternative before is, I was just, it was, for me, it worked out. Everything worked out good. I'm not perfect. I have some things that don't work quite like they did. But it wasn't the DBS that did it. It was, before anything that isn't working quite right is from before Parkinson's. Not my seeing voice is the same no matter what. So.
And I think Joe B had a question, and he's been waiting patiently.
Oh, sorry.
Hi.
Are you out there, Joe?
Yeah, I'm here. I had DBS in 2012, and I have stayed quite active since then. But there's been a couple different things. I used to scuba dive a lot, and I was told not to go below 30 feet. I wonder if you had that kind of instruction or not.
Nobody told me, so I didn't know. I don't go below 60 anyway, because I'm not, I think if you were supposed to be that far underwater, you'd have webbed feet. So I try to stay above 60, but nobody told me I couldn't, so I didn't worry about it.
Okay. Well, what type of equipment did you have?
What type of equipment? Like, do I do Knox or something?
I'm sorry, I meant in terms of your brain hardware.
Oh, I have rechargeable. What brand do I have, Dr. Ospina?
Boston Scientific.
You have the Medtronics RC.
Medtronic, and I got rechargeable, and I got rechargeable because at the time my father-in-law was getting a pacemaker, and he kept getting infections, getting stuff healed up, and I didn't want to. If they can get it in me once without getting an infection, I want to leave it in there. So that's what I did. And the charging's no problem. You know, you're supposed to charge it, I think, once a week, but it easy goes. This week I forgot, and I went 2 weeks, and it was only at 50% then, so I didn't have any problem.
Well, that's good.
I also had my DBS installed in 2012, and I opted for the non-rechargeable because Dr. Ponce and I both hiked the Grand Canyon, and we were worried that we wouldn't be able to access electrical current down there.
The charging equipment is much better now than it was in 2012. I also have rechargeable, but originally I didn't, so I had to go in for 2 surgeries before they put in the rechargeable. Because
I think that brings up a good point that, you know, your lifestyle, whether you're a Grand Canyon hiker or a scuba diver, there are those, you know, there's multiple companies manufacturing devices. So Dr. Ospina, is that something that you'd recommend people, you know, discuss with their doctor? Like, this is my lifestyle, and then, you know, the doctor recommends it, or is that a question with the surgeon?
Well, I think it's a decision you make together. So, you know, we've had one patient, you know, we like the rechargeable unit because it lasts 15 years and you're not going back to the, you know, the old batteries would last 5 to 7 years. Then when they came out with the next generation, since they did more stuff, they were only lasting about 2 years, maybe 3. So the patients kept going back to getting the battery changed out. And as Clint says, anytime you go back into the hospital, there's the risk of infection. So if we don't have to keep going back, we prefer not to. But depending on what your lifestyle is, you know, I had one patient where I had recommended the rechargeable, the RC unit. And even though they were a young patient, a good candidate, they were resistant. And it turns out that the reason was they like to go camping a lot. And they're like, well, what if I go camping and then I can't charge up the unit? So he's actually, you know, he actually ended up getting the RC. And as Clint says, the battery lasts long enough that if you wanted to go camping for 2 weeks, that would be fine. And, you know, if you use the Medtronics one, there's an extra charge in your charger so that even though you don't have access to electricity or a plug, you can still have one charge off of that. So it's quite flexible. And that if you're stuck somewhere or you went camping for 2 weeks, you should be able to still charge the unit. And as they said, before they, you know, when the RC first came out, Medtronic said, hey, you know, your patient could go and vacuum the house and be charging at the same time. That actually wasn't true. That just sit very quietly and make sure they got the 8 bars, or else the thing would take 4 hours to charge up. Today, the new technology is much easier. It's kind of like a little pancake that you put it over with, and you don't have to worry so much about how many bars you're getting, and it charges it fairly well. So so now you could sleep and be charging at the same time, or now that, you know, baseball season started up again, you can watch a baseball game and charge up. Usually if you charge every day, it's about 10 to 15 minutes. If you charge once a week, then it's about an hour. The longer you go between charges, the longer it takes to charge up the unit. And then it also depends how much juice you're using. So if you're on 4 volts, you're gonna need more charge than if you're using 2. So it all depends on what your settings are set at. But most of our, I think Arizona, we have most of the RCs in the country. We use more RCs, and our DBS is usually done asleep. Whereas, especially on the East Coast, they're still doing awake DBS, and almost nobody has a rechargeable unit. So we're a little bit
Arizona.
Arizona, we're more active. And like, who wants to be awake during DBS surgery? So maybe, Clint, remember, this is to tell them the good, the bad, and the ugly. So maybe you can tell them like what the actual surgery was like, post-surgery, that kind of thing.
Well, I did a sleep, so I don't know what anybody else did, but I did a sleep, and I wouldn't do any other way for a few reasons. One, it only takes half as long, so you're in and out pretty quick. And two, personal opinion, but my personal opinion is they can get it in the exact spot better when you're asleep, the way that they take a picture before. You go in a couple of days before, they take a picture of your brain, they pinpoint the spot, then they go in, put you in the headlock thing, drill the holes, then they put it in, if he's within 2 centimeters, so it's centimeters.
Millimeters.
I don't know, I was asleep.
I have a comment.
Yep.
I agree with the sleep method.
I have mine awake. I would like awake because they power it up and they know they're in the right spot. What happens if they don't get in the right spot and they don't test it?
Well,
this is my preference. They tested me. I had bilateral in 2016. What are your voltage readings?
For me, 3.5 on both sides, but I don't know what that means compared to anybody.
I'm 3.9 and 4.2, getting ready for my second new. I've got non-rechargeable. I'd like to hear the doctor's input on versus the non-rechargeable has a 15-year battery. But what about the advances that would lock you out from any new technology?
I think she's non-rechargeable has less. 15 years was a rechargeable.
Right. So there's studies that show whether you have it awake or asleep, that it works just as well. And certainly as neurologists and programmers, we haven't noticed, oh, gee whiz, the patient who was done asleep is much harder to program than the patient that was done awake. So the outcomes are virtually the same. And for the patient's comfort, it's much easier for them to undergo an asleep DBS than an awake DBS. So an asleep DBS bilaterally would be about 90 minutes, both sides. If you're awake, it's about 4 hours. So
mine was 9.5.
Oh, wow. 9.5. That's a record. So imagine awake 9.5 hours, stuck in a halo. That's definitely the Spanish Inquisition. So it's much easier to tolerate. And once we started offering a sleep DBS, the patients that were getting DBS shot way up. A lot of people who had been sitting on the sidelines were like, I don't know. As soon as we said, hey, we can now do it asleep, they said, okay, I'm ready to go. Because they didn't want to be stuck in that halo for hours on end. It's very, very uncomfortable. So one of the things is that, yeah, if you get a rechargeable, that rechargeable unit lasts 15 years. Now that there's 3 companies making hardware, that means, yes, if there's a new advance, we'd have to wait until you need a new battery to have the new technology. So usually you're locked into the lead. So whatever lead you got, that's what you're going to keep. And then as we upgrade the IPG or the battery, then you could upgrade every 2 years or as it comes out. So it hasn't really been a problem now, but now we're going to start to get a lot of new hardware very quickly, and we'll sort of see how it goes.
I'm leaning towards the non-rechargeable because It's Medtronic, and the new one can record brain activity and help with the settings.
Yep, so the new electronics hardware will have this sort of pacing system that we can still use with the old leads, but it works better with the new leads. But certainly as the technology gets better, then your IPG can do more things, and then your patient programmer gets upgraded as well. So it's all patient comfort and what they decide works best for them.
One of the things that's often forgotten that I came to realize is really important is not only who the surgeon is and how the surgery is done, but who is the programmer, how often do you see them, or how accessible are they, and is the programmer the neurologist, or is it the nurse, or is it every 3 months, or is it as needed?
Yeah, so Dr. Ospina, if you could talk really quickly about programming, but also before we hit the end of the hour, I wanted to talk about non-motor symptoms, and there have been questions about sleep, depression, anxiety, and speech, and how DBS, we've talked about DBS and tremor, but what about the non-motor side?
Right. So remember, it helps tremor and on time with dyskinesia. It dials out the tremor, dials up the dyskinesia. Anything that we get above that is frosting of the cake on the cake. So if your balance got better, if your sleep got better, we wouldn't be expecting those things, but if they got better, we would say, yay, we got more benefits. But we should never go into DBS thinking, wow, I'm gonna do DBS and my sleep is gonna be improved and my speech is gonna be improved and my freezing of gait is gonna be improved. That's not gonna happen. And if we get it, then it's frosting on the cake. Many times, if we can increase your on time, many non-motor symptoms get better. Your constipation can get better, the sleep can get better because we have more on time and we're not flipping that on off switch on your brain every 3 hours. So the benefits are from having more continuous on time, but you should never go into DBS thinking, I'm gonna have DBS and my constipation, my bladder symptoms, and my sleep is gonna get better, because that's not what's gonna happen. And then as far as programming, then what we do in our clinic, all the programming is done by the neurologist, by us. And then you have your programming, the programming starts 4 weeks after you have the leads put in. We want to have that swelling go away. And then we start to program your unit. Most patients, we give them control over their unit so that they can keep clicking up at home and we can go a little bit faster. Programming your DBS unit takes about 3 to 4 months. So it's not like you come in, we flip the switch on and we crank it way up. It's a slow, gradual process. And if you decide to use the programmer yourself, it goes a lot faster. So between your visits, every 4 weeks, then you could increase the voltage. So we would see you about once a month until we got that squared away. And in our clinic, we see you if we're making any changes, whether it's to your medications or to your DBS or duopa. We see you once a month. Actually, the duopas we see once a week until we get that titrated. And then if you're stable, we see you every 3 months.
So how about closed loop programming? How far it is? And do you see less frequent programming because of that, or how does it?
Tell me the first part of that question again.
So there's something called closed loop programming, where the programming senses your brain,
right,
and then it just programs itself.
So
automatically.
Right. So that the new Medtronic's IPG, I don't have any patients who've used it yet. So we're going to sort of see how that goes. And it doesn't really program itself. It just lets us know we're off time throughout the period. In the future, our goal would be that, yes, we could get something that can adjust to your dopamine levels, but this would just tell us what your beta is throughout the 24-hour day, and then give us a better idea. It's like, it's like doing your on and off diary. So it lets us know how many times during the day you're wearing them off, and it's sensing that beta. So far that just came out in July. We don't have any patients in the clinic yet who've had the new technology, and we'll just sort of see how it goes as we start implanting the new IPG.
I'm supposed to get my 3rd upgrade in 2 weeks.
Yeah,
so you'll have to report back then, Roger.
Exactly.
In the next 6 months, my battery would need to be replaced, and I'll get the new Medtronic hardware.
Right.
How long did that battery last?
I'm looking forward to that.
Mine has been like my first and second one last 2 years.
Yeah, mine too.
The new one is supposed to last 5 years.
That means
But
I
I didn't want to be locked out of new technology for 15 years. I want to get latest and greatest.
No. Well, let me have a question. Has anybody mixed the old technology and the new?
Dr. Ospina, what percentage or how much do you use with each of the manufacturers? Or how many?
I would say, since I have the majority of my patients are Medtronics, because that's what we've been using for 20 years. Then the next would be Boston, because they offer an RCA rechargeable. And then the least, although the easiest to program is the Abbott platform. But because they don't have a rechargeable option, many patients have opted out of that and got into Boston or Medtronics. But I think that once Abbott starts to offer a rechargeable unit, they have the easiest software to manipulate, to program, and also from the patient's point of view, to use as your patient programmer. It's an iPhone, and it's very intuitive for the patient, very easy for them to use it. Although the Medtronic's new platform is a Samsung phone, and it's also much easier than their old patient programmer. And then the Boston software is the hardest, the least intuitive one to use. And then both Abbott and Boston Scientific have a directional lead. So especially for essential tremor patients where they get a lot of dysarthria or the voice trouble, then, instead of having the whole ring on, we can just sort of turn a third of the ring on and hopefully have less of the voice side effects. And then eventually Medtronics will also have a directional lead. So there's lots and lots of choices today. And then it's a discussion you would have with your neurologist depending on what your disease is, what are you looking for? Do you want to, how often do you want to go back to the OR to change out your battery, and then decide which hardware you want to put in.
And we're so lucky that we have, that there have been some new advances in the technology with the 3 manufacturers, and a couple, I'm surprised how many people have surgery scheduled or going in for new batteries or whatnot. So thank you all for chiming in. And we are just at the top of the hour. So I want to give both Clint and Dr. Ospina, just put you on the spot to close us out. I don't know, maybe a message of hope or something to put a bow on today's session.
So I think, basically that there's lots of options, but, listen, we don't want the doctor to take over the whole thing. Clint, why don't you let us know how I always talk to somebody who's had DBS and ask them, what's the good, the bad, and the ugly, and would you do it over again? I don't know, what would you say, Clint?
I would certainly do it over again, because for me, I understand everybody, it affects everybody a little different, or they get a little bit different results, but it's a life changer for me. It almost doesn't, you almost don't get the effect of, unless you see a before and after with me, because I couldn't stay in this little square before. I was moving around so much, and you couldn't understand me because I try to keep settling down so I can talk. And yeah, I just say I had no quality of life before. And I always ask Dr. Ospina, what am I going to get to? Now, I understand that I might not be exactly like I was before. What can we do? How close can we? So she told me, and I passed it. But she told me, I can get you to 80% of what you were before you had Parkinson's. And I don't know, maybe I'm not, but I think I'm way past that. So yeah, it's good. You got to keep working out though, or keep, I work out, but you got to keep moving, because you can still get benefits from it, but you can get a little bit stiff, because the more you move stuff, some of the things that were hard to do, your brain teaches a new way to do it. But if you don't keep trying and keep doing the stuff, you don't learn the new way to do it. So yeah, I'd do it again in a heartbeat.
Very good. Well, thank you for joining us, Clint. Your workout routine, very impressive. And Becky put in the chat our YouTube channel. So it takes about, 12 to 24 hours, but we'll put a recording of this up on our YouTube channel. And yeah, thank you, Clint. Thank you, Dr. Ospina. Thank you to everyone who joined and chimed in about their own personal experience, and everyone who asked their excellent questions. Stay tuned. We have plenty more programs planned for the month of August and beyond. And we hope that we will see you online often and soon. So let's, we always do a goodbye wave. This is our chance to get some eye contact and smiles from our new friends across the country. So thank you everyone for joining us. Thank you again, Dr. Ospina and Clint, for sharing your time with us.
Thank you. Bye-bye.